So if we compare the overall etiology and the pathophysiology of both boys and girls, we will understand that delayed puberty is much more common in boys, but the likelihood of pathology is lower. So we need to be very careful in terms of not doing unnecessary workup in these scenarios because that can cause more confusion. So this was a 13-and-a-half-year-old boy with delayed puberty who was referred with a testicular volume of just 3 ml and pubic hair stage 1. So parents were concerned that there is delayed puberty. He was relatively short for the family with a normal weight. On investigations, he had undetectable LH and testosterone. Now, based upon this, the treating physician made a diagnosis of hypogonadotropic hypogonadism and advised a MRI head. Now, this was a very troublesome situation because parents were really concerned about not only the short term, but also in terms of the long-term future of the child and also whether there could be a pathological cause in that perspective or not. Now, if we can look at this case very carefully, we'll see that this is too early an age to evaluate for delayed puberty. He is probably going in more like a constitutional delay of puberty and growth, if at all anything. So this child should not have been worked up at all in this scenario. So I think this gives us an idea as to how so many cases where workup is not done, we are unnecessarily causing confusion in terms of evaluation. Contrary to that, we had the 16-year-old boy who presented with pubertal concern, who had an onset at 13 years. So puberty had started and then it stopped for 2-year period. At that point of time, when the child was seen by a physician, it was found that he had a testicular volume of 3 ml, which was soft. He had pubic hair development, which was a proof that there was a development to start off, and now the development has stopped. He was reasonably tall, and then he was labeled as constitutional delay of puberty and growth from that perspective. So this case scenario, in fact, if you look at it, there were everything which was going on, which was against the diagnosis of CDGP. This was a 16-year-old boy. Of course, there was the onset of puberty. The testes were there, and there was pubic hair development. The height was normal. So these are all against CDGP. So when we talk about that, we'll discuss about what are the pointers which go against CDGP. In this case, clearly developed and was found to have a brain tumor, which was causing these problems in that perspective. So this was a case in which we had missed the pathology. So in evaluation of puberty, which is a common scenario, 5% of all boys have delayed puberty. Physiological causes are common around 70% of cases. 30% have a pathology. What's important is that we do not do unnecessary workup in these 70% as was done in the first case, while we do not miss a pathology in the second case of 30%. This whole talk over the next 1 year, we'll discuss about the strategies about how to not do unnecessary workup while not missing on pathologies. All these resources are available in our website learning.growsociety.in, which offers a lot of resources as well as courses in pediatric endocrinology. We have our e-learning videos, so a lot of free stuff is also available over YouTube. There is option to look into our different courses, including fellowship courses in pediatric endocrinology and pediatric endocrinology for postgraduate courses as well. We frequently run grand rounds along with the PG lecture series and journal clubs to highlight these common scenarios. The books are available both online as well as the e-versions. Our app will help solve a lot of these problems. We'll try to see how it will help here. And today our focus is predominantly on delayed puberty in boys.
If there is no pubertal development by the age of after the age of 14 years, then we should concern and we should then investigate. Investigating before the age of 14 years lead to unnecessary investigations and also parental anxiety. So broadly, etiologically, delayed puberty in boys is broadly classified into two groups. First is hypogonadism hypogonadism, in which the LH FHS levels will be low, and it will involve hypothalamus and pituitary. Second group is hypergonadotropic hypogonadism, in which the defect is at the level of testis and the LH FHS level will be high. So the most important cause, 70% cases are assigned in physiological or self-limited, also known as CDGP. In the pathological causes, we have 10% cases of hypergonadotropic hypogonadism due to testicular dysgenesis, skeletal syndrome, torsion, insult, and stereogenic defects. In hypogonadotropic hypogonadism, we have 10% functional cases due to malnutrition, systemic illnesses, hyperprolactinemia. 10% permanent causes in which we have multiple pituitary hormone deficiency due to genetic insults or acquired insult and infections. And we have isolated GNRS deficiency due to various genetic defect like KIS1 GNRS defect, CAL1 defect, FGR defect. In the physiological causes, in the functional causes, in MPSD, there will be short stature and there will be no puberty. However, in case of isolated GNRS deficiency and hypergonadotropic hypogonadism, there will be puberty. Apart from this, in hypogonadotropic hypogonadism, there will be low LH-FSS, and in hypergonadotropic hypogonadism, there will be high FHS to start with, and later on there will be high LH. So this is we will now discuss about self-limited delayed puberty, which is like most common, and 70% cases are assigned. It is usually familial and like it is autosomal dominant, and usually it is associated in 50 to 75% of the cases and can be inherited from any of the parent. In this, we have a suppression of GNRS axis, due to which we have low LH FHS level, and which will lead to low testosterone. Usually, morning testosterone is less than 20. But the inhibin B, as already discussed, it will start rising before the puberty, and in this scenario, it will be usually more than 35. These cases usually have antenatal exposure of GNRS to the gonadotropes, so they will respond to the GNRS stimulation test, and the GNRS stimulated LH will be more than 5, and HCG stimulated testosterone will be more than 200. A trial of testosterone can be given, and they usually respond after 3 to 6 months of testosterone, and there will be a progression of puberty. It is usually self-limited, and there is usually they subside by the age of 18 years. They have effect on growth. Initially, there will be growth delay, there will be a delayed bone age, and they also have psychosocial impact. The treatment is observation, and in selected cases, we give a testosterone course of 50 to 100 mg per month for 3 to 6 months, which will lead to progression of puberty. As already discussed by Sir, GNRS neurons are developed along with olfactory neurons by the age of 5 to 6 weeks in olfactory placode, and subsequently they are migrated to hypothalamus by the around 12 weeks of gestation. So there are various genes involved in this migration, and the defects in these genes can lead to GNS deficiency. Along with there can be variable anosmia. Very important is anosmin 1. Apart from that, we have CDH7, FGFR1, we have IGS10, PROC-K2. They have variable anosmia, and they present with isolated GNRS deficiency. Importantly, anosmin 1 defect, also known as CAL1 defect, it leads to X-linked congenital hypogonadotropic hypogonadism, also known as Kallmann syndrome. In this, there is defective migration of the GNRS neurons. It is severe, variable. It will lead to, in neonatal period, there will be micropenis, cryptorchidism, there will be anosmia, cleft lip, cleft palate, there will be teeth hypoplasia, synkinestic movement will be there, ptosis, hearing abnormalities can be there. Apart from this, there can be renal agenesis, dental anomalies, and it is rarely reversible. Other important causes in the migration defects, we have CHD7 defect, also known as Char syndrome, which stands for coloboma of eyes. We have heart defects, corneal atresia, retardation of growth on puberty, genitourinary abnormalities, and ear hearing defects. It is due to CHD7 defect, and as already discussed, coloboma of eye, hearing defect, dysphagia, cardiac defects, cleft lip, cleft palate, corneal atresia, urinary tract abnormalities, tracheoesophageal fistula can be there. There are few genes which are involved in the regulation of GNRS neurons, like KIS1, KIS15, KIS1 receptor, TAC3 receptor, GNRS receptor. All this lead to non-syndromic causes of GNRS deficiency. Apart from this, we have leptin and leptin receptor, which will lead to obesity. So briefly about the summary of genetic causes of isolated congenital hypogonadotropic hypogonadism. Anosmin 1, which is X-linked, there is anosmia is present and there is no reversibility. Presents with synkinesia, hearing loss, and renal defects. FGFR1 presents with skeletal abnormalities. There will be hearing loss, synkinesia, and it is reversible. CDH7 presents with Char syndrome. DAX1 presents with congenital adrenal hypoplasia and hypogonadism. GnRH receptor, KIS1 receptor, TAC3, they are usually causes of non-syndromic isolated GnRH deficiency, and leptin receptor present with obesity and hyperphagia. Genetic MPHD is again one of the important cause. We have various genes like HSX1, which is involved in the early embryogenesis. It will lead to suboptic dysplasia. PROP1, it presents with growth hormone, TSH, and prolactin deficiency, and later on GnRH deficiency. POW1, F1 presents with growth hormone and GnRH deficiency. LHX3 presents with spine defects. Functional GnRH deficiency is again very important cause, and we should rule out this before going to extensive endocrine investigations. Malnutrition, anorexia, systemic diseases like celiac, renal disease, liver disease, infections like chronic infection, tuberculosis, endocrinopathies like hypothyroidism, Cushing syndrome, type 1 diabetes. All this lead to low leptin levels, and there will be a suppression of GnRH axis. So eventually there is low LH-FHS, and which will lead to low testosterone, delayed puberty. These patients usually have poor growth. There is a lack of puberty, and we should do a systemic workup and make the diagnosis. Importantly, they are different from CDGP because they look more ill than the CDGP patients, and we would correct the underlying cause before going for extensive endocrine investigations. There are various obesity-related syndromes which are associated with the GnRH deficiency, like Prader-Willi syndrome. We have in this hyperphagia, obesity, acromicra, and almond shaped eyes. Laurent-Bardet-Biedl syndrome, we have polydactyly and renal anomalies. Alstom syndrome, we have eye defects. Char syndrome is a spectrum, and Robinow presents with cardiac defects. Mass lesion can lead to acquired GnRH deficiency, and it usually presents with stalled puberty and pressure effects. Various causes are like macroadenoma, stalk thickening, craniopharyngioma, pituitary cyst, rat case cyst, and germinoma. In such cases, MRI head is warranted. Radiation has a variable effect. In low doses, there is suppression, there is interruption of the inhibitory signals, and it will cause early puberty. And in high doses, there will be destruction of the gonadotropes, which will lead to delayed puberty. Infiltrative disorders which present with stalk thickening, sarcoidosis will have rash, nodule, there will be hypercalcemia. Histiocytosis will have rash, seborrhea, there will be diabetes insipidus, and autoimmune hepatitis usually presents with headache, mass effect, and early acidic involvement. Very important is Klinefelter syndrome, which is one of the most common causes in hypergonadotropic hypogonadism. It presents with initial pubertal development, and there is an arrest at a later stage. The patient will be tall, there will be a large arm span, there will be large legs, and many patients will have gynecomastia at presentation. There will be small, firm, and shorty testes. There will be a small phallic size. It is usually associated with mediastinal HCG producing tumors, type 2 diabetes, CA breast, and cardiovascular diseases. It is diagnosed with the help of karyotype, where we will find an extra X chromosome, and most common karyotype is 47XXY. Incidence is 1 in 667 male births, and treatment is testicular extraction of sperm and then intracytoplasmic implantation. Biosynthetic defects are very important. In the milder form, they present with delayed puberty. The DSC7 defect, Smith-Lemli opioid syndrome presents with salt wasting, and there will be syndactyly. SSC and star defect presents with salt wasting, and it is usually severe. 3-beta hydroxysteroid dehydrogenase defect presents with salt wasting and DSD. Milder variants will present with delayed puberty. 7-hydroxylase deficiency usually present with hypertension. And 17-beta hydroxylase steroid dehydrogenase defect presents with delayed puberty. There will be sex reversal, and milder form they will have delayed puberty. A summary of steroidogenic defects with XY-DSD. DSC7 present with syndactyly and salt wasting. There will be low cholesterol levels. Star and side chain cleavage defects present with salt wasting. There will be low metabolites. 3-beta HSD defects present with salt wasting. There will be high pregnenolone levels. 17 hydroxylase defect will present with high hypertension. There will be high DOC levels. 3-beta hydroxysteroid dehydrogenase 3 defects presents with complete reversal. There will be high androstenedione to testosterone levels. P450 oxidative defect presents with salt wasting, and there will be high 17 OHP levels. Androgen testosterone is converted to dihydrotestosterone by 5-alpha reductase 2, and which subsequently acts on the androgen receptor to cause the effect. So if there is a defect in the 5-alpha reductase 2, there will be defect in the testicular activation. The testo to DST ratio will be more than 10. At puberty, this excess testosterone will cause virilization, and the gender of rearing will be male. Mullary structures are absent, and management is with high dose of testosterone and local application of DST gel. In complete AI syndrome, there will be defect at the testicular action at the level of androgen receptors. So DST level will be high. The testo to DST ratio will be less than 10. At puberty, this testosterone will get converted to aromatized to estrogen and will cause feminization. Gender of rearing is likely female. Absent Mullerian structures, treatment is with gonectomy and further estrogen therapy. Cancer has various effects. It affects the germ cell, it affects Leydig cells, it affects the spermatogenesis. It will lead to small testicular size, and alkalizing agents like cyclophosphamide in a dose of 200 mg per kg will lead to testicular failure. The assessment is done with testosterone, LH, semen analysis, and treatment remains testosterone.
All of you can go and have a look at our website where a lot of publications are available, our app, which will help you in terms of evaluation and management, join our courses, and look at free resources in our website.